To begin dressing change, we will be following our hospital policy. So the initial dressing change needs to happen 48 hours after the insertion. And by default, nursing staff is able to change the dressing unless otherwise specified in the patient's chart. So we're gonna go ahead and just put on regular gloves. We're gonna go to the site of the insertion, remove the old dressing, and with sterile saline and gauze, clean around the insertion site. Then we're gonna take after this, we will remove the old gloves, hand hygiene, and put on sterile gloves. So pretending that these are sterile, we're gonna open up our split gauze. So one piece of gauze will go over the top, from the bottom, and then the other one will go from the top, just like that. Then you will have your regular 4x4 gauze. Put that over, and then with tape, provide tape on all 4 sides. And that is how you change the dressing on a chest tube. So when identifying a leak on the patient's chest or like the insertion site, we want to palpate around the insertion site to identify any crepitus or subcutaneous emphysema. If there is any, it will be reported in the patient flow chart. Then we go on to the actual chest tube system, and on this bottom right corner, you will see this gradient 1, 2, 3, 4, 5. So if there is a leak, you will begin to see bubbles begin to accumulate and like travel from 1 to 5. The higher the number, the more serious the air leak has become. So that's 2 ways to identify a leak in our chest tube system. One is on the patient's chest, the insertion site, and then the other one is here on the actual chest tube. The chest tube system. Now we will be reviewing in case there is an emergency dislodgement, what to do. If the chest tube gets dislodged from the collection chamber, we will submerge the chest tube into 1 inch of sterile water. So this is where, if this gets disconnected from the chamber, we will grab our sterile water and submerge the distal end of the chest tube into minimum 1 inch of the water, and then immediately page the physician and handle the emergency. Also make sure to assess our patient to make sure that they have not gone under distress. In this second scenario, if the chest tube becomes dislodged from the patient, we will then immediately grab our petroleum gauze, place it over the insertion site, then grab sterile gauze, place it over the petroleum gauze, and we will only tape either 2 or 3 of the sides, leaving one side open, allowing air to exit from the insertion site. So now this last section, we will be reviewing when to notify a provider. So if there is a sudden increase in drainage or the presence of bloody drainage, if there's any dyspnea, rapid or shallow breathing, cyanosis, decreased oxygen saturation levels, subcutaneous emphysema, chest pain, or excessive bleeding. And then lastly, if there's any disconnection of the patient's chest tube from the chest tube connector or the chest tube chamber, those are all valid reasons to immediately page the provider. And that is it. I hope this review has been useful. And if you have any questions, please feel free to look online and visit the UCLA Hospital Policy Guidelines and also the Lippincott Procedures website for any questions. Thank you so much.